Well, welcome. I am Nancy Muir from Miles for Hips, and I have the absolute privilege to be here this evening, their time, with Holly Doyle and Kartik Logishetty. Holly is a APP physiotherapist at Cambridge University Hospital in the UK, and Kartik is a hip surgeon at the University College London Hospital. And I appreciate you both being there. I know it's quite late your time, even though it's only lunchtime where I'm at. So especially appreciate you taking the time.
Our pleasure,
Welcome.
Nancy. Thank you for having us.
So ready to dive in, but I would love to hear from both of you. Tell us a little bit about yourselves and what brought you to being interested in hip dysplasia.
Well,
Um,
my name's Kartik Logishetty. I'm a consultant hip surgeon at University College London Hospital. As Nancy mentioned, I mainly specialize in hip preservation surgery. So that's in the spectrum of hip disease, really, starting from patients who are usually 14 to 16, that kind of age group is the youngest, with conditions like dysplasia and femoroacetabular impingement. And the spectrum of my practice involves arthroscopic work and open work like periacetabular osteotomies. And of course, in patients who require it straight away, or maybe as a sequelae of their young adult hip pathology, I'll be thinking about hip replacements as well, and then redo hip replacements further down the road. I work with Holly in London. We share some patients as well. I'll let her introduce herself.
Hi, I'm Holly Doyle. I work as an advanced practice physio at Cambridge, and then I also run hip dysplasia physio. So I have a website and online following with Instagram where I do rehab and discussions and patient help. And then how I came to be interested in hip dysplasia is because I was a young physio and I myself got diagnosed with hip dysplasia. And I then ended up having a PAO myself, and then also a shelf later down the line, a shelf acetabuloplasty. And so I kind of felt that there wasn't enough out there for physios or patients around. And so really wanted to use my own experiences to kind of help raise the profile of dysplasia and help patients and clinicians alike.
Well, actually, Holly, you've got a great origin story, and I haven't really got one as impressive as that. I'm not a patient of hip preservation, but I would say that my interest in hip preservation came when I was a medical student. So we're talking over 20 years ago. My first introduction to research at all was at Imperial College with a surgeon called Professor Justin Cobb, and the interest of the lab was to make what was previously two-dimensional understanding into 3D. So my first foray into research and into hip preservation was understanding the 3D shape of hips with dysplasia and comparing them to those who are overcovered and those who are normal, and finally being able to work out where things were shallow and where things were normal, to then optimize our correction. And so now that's what I do day to day, and it's been with me for the bug has been with me for 20 years, I guess now, and it's my passion both clinically and I run a research lab as well that investigates how to improve outcomes in hip dysplasia.
Well, wonderful. And we are so lucky to have you all. And like I was talking to you before we even started the recording, but you are the only pair of individuals that we have on one of these interview days. Everyone else is just single interviews. So this is, I think, really fun and hopefully gives us a little chance to have maybe a little bit more discussion than might also be possible. So once again, so excited to have you. This first question, I know you both work more in on the adult side, and this is maybe goes down to a little bit more on the pediatric realm as well. But as we know, hip dysplasia is a spectrum condition, and it's a lifelong condition for many individuals. And because of the nature of it, that's how adults end up finding you both in your in their practice. But was just wondering if you could talk a little bit about in the UK, just some information about how what the hip dysplasia screening is like and how patients are come to be diagnosed with hip dysplasia in your country. And I guess maybe you could speak to it a little bit from infant screening, but also then how individuals, either because they're missed or re-diagnosed later in life with ongoing issues, would make their way to you all.
Okay, so I'll start, as I say, I don't specialize in pediatrics, but I'll start with the peds bit and then I can hand over to Kartik to do the young adult hip side that we do. So over here, we don't have universal screening. As a baby, you get hip tests done in hospital, hip checks, and then those have to be done within 72 hours. And if anyone has a family history, breech birth, twin birth, those risk factors, then they are referred on for a scan at 6 weeks. They have an ultrasound scan. The other way that babies are also picked up is at the 6 week check with the GP or the health visitor. If you're noticing uneven creases, then they may go and have their ultrasound scan. And then not all of those centres have then an ability for a one-stop shop treatment pathway, i.e. they scan on the day and you're put into a Pavlik harness on the day. It might be then that you're scanned and then you're sent again for a later appointment down the line for treatment from the baby side of things over here.
Yeah, I mean, that's obviously a very lovely summary, Holly. I think the only thing I would add is that I don't think that we are moving towards universal screening in the UK like some others have. I mean, certainly some countries in Europe have been there and have now reversed, like Switzerland. Some countries are still there and doing it. Ultimately, it comes out down to not just the cost, but cost effectiveness in terms of, does it, of course, it costs a lot of money to scan every single baby, but also there is a certain burden with overdiagnosis and whether it makes a difference. So at the moment, the signal for the UK is that what we're doing seems to have comparable outcomes to the best places in the world. I don't think we're going towards a universal screening as far as I'm aware. And for good or for bad, people like me and Holly are the safety net in a way for catching the ones that not necessarily were missed dislocations, but have hip dysplasia that became symptomatic, usually in the teenage or early 20s. The patients who are frankly dysplastic and who were missed, as in congenital dislocation of the hips, they're usually picked up a lot earlier than me or Holly would see. And that obviously is one of the worries of not having universal screening. But thankfully, number one, that is rare these days, certainly in the UK. And number two, when it is caught, it is quite reversible, and the treatments are very effective when it's caught early. Even, and Holly's obviously mentioned Pavlik harnessing. There are a bunch of different things we do for our babies that mean that they never get to see me or Holly, which is obviously a good thing.
That's wonderful. And I know the universal screening is such a debate, and I've been speaking with some individuals here in the United States who are hoping that we'll be moving more towards that trend. I know we have another board member interviewed a surgeon in Mexico, so we're looking forward to hearing that because I believe they do have universal screening there, and it's going to be interesting to hear the pros and cons because, like you said, it is complicated, and there is a cost benefit ratio that to meet at some point. Anyway, it's a very interesting debate, and I think that's something that people are going to be interested to learn more about, just to understand the nuances around it.
Yeah, it's such a nuanced thing, Nancy. I think that it's contentious because it
Mhm.
feels like screening everyone would be the right thing to do, but also it's about the local understanding and knowledge. So, Holly mentioned we have this newborn and infant screening program. It's called the NIPE, and one of the elements is the hips. And
Mhm.
the doctors here and the midwives and surgeons and physicians as well are all trained to do that at that time point. And
Mhm.
clearly, it is in their hands, sensitive and specific enough to pick up most problems. But then we don't know about other places in the world where they may not have that kind of program as a backup, the same training. So there isn't a right or wrong answer to this.
Yeah, and I loved, I thought it was really interesting. That's a program I'm not familiar with, and I'm going to definitely be looking into it a little bit more, because I think stories that I've heard where dysplasia has been missed or caught a little bit later, it sounds like, at least with people in the United States, is that things have been missed as far as like family history. And the physicians have not realized that that's a screening question that needs to happen. And that makes me wonder if, I feel like there are still steps maybe in between the Orlo or the Barlow and the Ortolani screenings that happen that we know are not maybe the most sensitive or specific exams, but also between that and universal
Totally agree.
ultrasound assessment and it sounds like the UK is maybe doing some really nice things with having these very mandatory steps and questions that are asked. And making sure that the screening questions happen as far as the history. So that's really interesting, and I'm definitely going to be looking into that a little bit more myself, just working in pediatrics like I do. So then, and I know both of you work more in the adult world, so I'm fine with us moving forward more with that kind of conversation. But you talked a little bit about, if the ones that maybe either slip through or have more mild dysplasia or more acquired dysplasia that end up having the symptoms later in life and make it into your clinics. And once a patient is diagnosed with hip dysplasia, what would you say a typical care pathway looks like? Is it very patient dependent, or is it usually a role for non-operative management first, followed by surgery, or what would you say that looks like in the UK?
So I think the first thing we should discuss is then from the last question in the
Mhm.
screening in the young adults.
Sure.
So for myself and Kartik, we would certainly be using that history when we're taking our history from our patient in the clinic and looking at, have they got family history? Were there any problems as a child? Were they harnessed, double nappied? We ask all those questions. And often if my young patients are coming with their mothers, I'll ask for all that history. When they walked, was it in a timely manner? Because if we haven't got any suspicion at all, we want to start to see if we can see that pattern from their history. And then often they don't get to myself or Kartik because we're in what we call tertiary centres here. So it's quite a long pathway to even get to us. So they'll often have been, back and forward to a GP, probably over many years. They may have had an X-ray. They may have seen an orthopedic doctor in a primary sort of standard local hospital. And somewhere along that pathway, they may have been detected with dysplasia, or they may not have done. And as I said, some of them have had X-rays, but often they come back when they've been done by our local GP. They come back that there's no fracture, there's no arthritis. And sadly, quite often I see quite frank dysplasia missed on an X-ray, and it's not commented on because it's not looked for. The question hasn't been asked in primary care. Does this patient have dysplasia? It's just, is there an issue? And that issue seems to be, is it arthritis or a broken bone? And so it takes quite a long time before they end up seeing someone like myself or Kartik in the hospitals that we work in. And then, I'm sure it's been mentioned before, but the Nunley study that was done in 2011 showed that it's on average 5 years to even get that diagnosis, having seen 3 or 4 clinicians. So that pathway is quite long and laborious to get to myself or Kartik. And then for us, that certainly when they come to see me, because my advanced practice role, I work alongside the consultant, so I'm newly diagnosing. So we will do an X-ray of every patient that attends in clinic, and then obviously I can do all the angles and look for things like dysplasia or femoroacetabular impingement and get that kind of gold standard starting point. And then we might want to then screen onwards to do an MRI or a CT. So your MRI would be looking at cartilage health, labral tears, and the CT would then be looking forwards towards 3D planning, or also torsional profiles, looking down the whole limb alignment, and getting a 3D model of what exactly the hip coverage is. And certain places have 3D graphics that can plan out the whole mapping of the femoral head coverage, which is an amazing AI system. And Kartik is exceptionally well versed in all this, so he can tell you more on that.
Yeah, I think that the pathway which Holly described is unfortunately all too familiar to lots of the patients that see me as new patients in my clinic, meaning that they've seen lots of medical professionals along the way. I think the role of this call, your group, Nancy, the International Hip Dysplasia Institute, is to raise awareness and education not only to patients but actually to orthopedic surgeons as well, because and physiotherapists too, because as Holly and I were saying, 1 hour sometimes of a curriculum of years is devoted to what we're talking about today, but it is a life-changing thing to miss, and it affects patients through their most productive years socially, in their relationships, academically, professionally. So it is just something that the pathway needs to be optimized wherever in the world we're talking about. So if we can accelerate the time it takes between a patient complaining of hip pain, presenting to their primary care practitioner, their general practitioner, and seeing the likes of me and Holly in tertiary units, without prior intervention as well. That the issue is that sometimes, and this is certainly not besmirching all of my colleagues by any means, we have really good people all over the country, but having procedures that they may not have needed as well, I think is very important. And all of that comes down to education. And certainly, places like UCL, where there's 3 or 4 young adult hip surgeons like me, we see so much of it that we are almost biased in terms of our knowledge and understanding of it, that we think everyone should be seeing it and understanding it. And that's just not true, because there's all the rest of the medical textbooks to look at. And then, as Holly was saying, that there are different centers have different modalities of imaging that they prefer. So, X-rays are de rigueur, and usually we get standing and supine X-rays because they tell us different things about hip spine mobility and patient's dynamics and so on. And then, MRI and CT are just, the baseline. In my particular institute, in my experience, we tend to get just the CT alone, the MRI in a handful of patients. But often patients come to us with MRI scans. And these days we have technologies that extract just the bone out of the MRI scan and give us a beautiful 3D model for our PAOs. And as Holly was saying, some of our research here at UCL and also, around the world is to do with, getting the correction right. So someone's coming to see us with hip dysplasia, and you want to make them quote unquote normal. Where should that acetabulum be positioned once we've done, some of the releases and the cuts to the bone to help us free it up? And that's what the 3D planning allows us to do. So we can simulate where the PAO should be going and how the cuts should be and so on, and mimic those in surgery with some navigation and with 3D printing and so on. And that gives us a better, let's just say it reduces the chance of that socket not being exactly the right position. Because the last bit to say is that in the pathway is what happens after the patient leaves. Let's fast forward a year or 2 down the line. We know that patients, actually, Reinhold Gantz told us this 30 years ago when he discovered FAI, was that the patients who aren't particularly happy after PAO surgery are the ones that go from people who are dysplastic to accidentally being impingers, because we actually created a problem. So I think, me personally, it's a bias of mine from my background and so on, is that 3D planning and 3D printing and 3D navigation and so on are just part and parcel of PAOs in 2025.
No, I think that is so important and so poorly understood, as I think even in the last 10 years, we went from going, well, some patients just don't have great outcomes. And we're starting to understand more and more that there maybe are some reasons behind that, and some technology coming along.
And one thing I think, Holly, you and I didn't really talk about was prehab and rehab. Part of that pathway we can get into, Nancy, in time, is just getting patients as fit as they can be, because a lot of them may not need surgery at all. We have to give them absolutely everything from a conservative standpoint, from basically retraining how they move, and strengthening them up. So, and Holly will, I'm sure, go into this in much better detail, because this is not my wheelhouse and expertise. So we can get to the point where they are at least functioning at a level that it may be uncomfortable from time to time, but they don't, the risk benefit of having major surgery like a PAO is it's a serious operation. So we can avoid that entirely with great prehab. We can essentially delay or definitively not need surgery at all. So Holly, maybe you can explore a little bit more about what an optimal physio program for someone with dysplasia looks like as part of the pathway dream world, and what today's looks like in the UK.
Yeah, so I think that was your question that I kind of digressed a little bit on. But once we have the diagnosis, again, it depends on what that pathway has been. But if you think about me in a tertiary centre, we're trying to standardize it. So even if they've had physio elsewhere and they say, oh, it didn't work, we start them straight at the beginning. And the first port of call for that is education and understanding. And the education is so important. How do I load with pain? What is hip dysplasia? How do I load for my hip, my anatomy? So if you've got a hip that you're uncovered at the front, can you do some anterior tilting of your pelvis to try and improve the functional coverage and then load in that area? Again, if you're retroverted, instead of doing squat straight line, just squatting with slight external rotation. Just something as simple as that can be like the difference between someone failing physio in the past to them loading their hip correctly for their anatomy. And so that understanding is so key. And that buy-in. So often, as I said, a lot of patients come in and they're just like, physio is not for me. They've done lots of what I call open chains, so waggling the leg up in the air, clams, which can be really provocative on the front of the hip because it often irritates the anterosuperior acetabular rim, so the front of the socket, where often we have the labral tears. And those sorts of exercises just hinge off that area and give a lot of pain. So it's all about that modification and buying the patient into wanting to do that rehab. And then I'm trying to sort out the pathways at the moment where I work in terms of my private stuff, my NHS stuff. So then they will come in and they'll be assessed. Then they'll go into an outcome assessment. So that will include outcomes like IHOT-12, looking at anxiety and depression scores, looking at functional outcomes of strength, range of motion, special tests that we use specifically. And then like strength testing, both with the dynamometer and then also things like a leg press, a single leg rise test. And then once we've got that data, then it will end up going into a strength and conditioning class. So that would be for probably 6 weeks. We might push it to 8. It just depends, again, what the NHS will allow. But within that, there will be a 10-minute education component at the beginning of each class. So understanding your dysplasia, pain and dysplasia, diet and dysplasia, modifications that you might need, so symptom modification. And then patients need to do a minimum of 6 months of good strength training to see positive outcomes or to see benefit. And then if at the end of that pathway, so at 12 weeks, we would redo the outcome measures. And then at 6 months, we would redo the outcome measures again. They'd do the class, and then they would have sessions of physio once a month to continue their physio and progress through the pathway. And it should look like strength training, starting double leg, working to step stance based stuff like a lunge, split squat, and then on to single leg based rehab. Because if you think about what our day is, climbing a stair is like doing a single leg squat, single leg heel raises is a huge important component for walking. And again, if you're weak in your calf muscles, you drive through the front of the hip, you cause a lot of shearing through, again, that anterosuperior rim and where often the labral tears are. And so that can cause a lot of your pain and symptoms. And simple things like adjusting posture, gait, the way you load and how big a step you take can make a massive difference to pain. And then so by the end of 6 months, hopefully someone should be on their single leg strengthening rehab. And then if it's 6 months outcomes, we go, right, they've got stronger. We can see that through the pathway, but their pain hasn't changed. Then I can start to send them down a surgical pathway and say, right, this one, can we consider for surgery now? If then a patient is doing really well and has seen good positive changes in all their outcomes, both strength and pain, and obviously their mental health, then also we can carry them on the physio pathway and keep that going with a positive outcome. And again, there's great debate over here over kind of long-term management and stresses on the health system and whether we should keep re-x-raying because we don't want to miss that window of opportunity for that hip preservation. So for me personally, it doesn't happen in my unit. But for me personally, I've been lucky and have been kept on and monitored my hips. But now with the stress on the health industry at the moment, we are kind of saying, right, if you're good, off you go, carry on, manage yourself, come back to us if some pain starts. I don't know your thoughts on that, Kartik.
Well, I wanted to comment actually a bit about the patients who, come to see me as a new patient or come, via someone like you. And I say, you're having surgery and I think that's the best thing for you. And the patients who I say, I think you need to at least complete 6 months here of really focused physiotherapy, the program that is evidence-based, like what Holly outlined. And I think for the people viewing and my understanding of it is that there are obviously there's a range of how severe hip dysplasia is, and some people have quite severe hip dysplasia that I personally, and Holly, you can disagree with me, I think that no amount of physical therapy is going to stop them benefiting from an operation at some point. And for those patients, I would just immediately list them for surgery. And again, for good or for bad, the waiting list, my waiting list is probably somewhere between 4 and 6 months, on a good day. And that gives us ample opportunity to do all that stuff. But they're already in their head saying, I'm working towards surgery. And there are some patients in this phrase called borderline dysplasia, or the angle numbers, which no one can agree on anywhere in the world, but leave it to the surgeon to work out what he or she feels by borderline. Those are the patients I think, hey, you have, I call it mild dysplasia. And that's not underplaying the severity of your symptoms, but let's give it a go here because I think you have a good chance of really benefiting from not needing surgery. Mm-hmm. I'll see you in a few months' time and go from there. That's the only thing I would add to anything you said there, Holly. That's great.
Yeah, I think I agree with you in some part, but I think the thing is, and that's why we need a standardized care pathway. We have no standardization on the research of what should physio even look like. We don't have any standardization on whether we operate on someone who's 1 degree under normal versus 20 degrees under normal. And we don't have any standardization on all research that comes out and shows us, oh, this is what I'm hoping with all the stuff I'm working towards, is that I can then pick groups and say, oh, right, I can see that the borderlines do really well with this program. However, the more severes don't, and they end up having surgery. Or I can say, oh, the anteriorly dysplastic patients do much better than the posteriorly dysplastic ones, or vice versa. Or if you put anterior dysplasia with slight retroversion, oh, they don't do great and they end up needing surgery. So we'll start to see these groups and these patterns come out, and that should then frame the research, and hopefully, obviously, I can make it into a research project. I mean, being sat here and putting my patient hat on, I have under 10 degrees.
I knew you were going to bring this up.
And every single person has said, I can't believe you've managed to keep that hip and it hasn't progressed with arthritis. And it's because until I had my little one, I was very, very, very strong, and I was super strong, but I still don't have any problems. And I do truly believe that the strength training I do and the proprioceptive work I do makes the difference. But every single person will say that hip will fail, you'll need to have it done. As I said, I've been very lucky because I've been monitored and I know it hasn't progressed to arthritis, but I'm one person. So it's irrelevant because I can't prove it yet across the world in terms of it can be done, but I can tell you it can be done because I've done it.
And I think Holly's a great example here because you've got someone who's highly motivated, highly knowledgeable, world-class knowledge on the problem that they have, and you have a aberrant or unusual outcome on what they're doing, and that's one side of things. The other side of things is we're talking about numbers here, but actually a hip surgeon or a physio or a patient shouldn't chase a number. Every patient behaves and reacts differently. They have comorbidities, things like hypermobility or chronic pain or other issues with other joints, or they've had previous injury. Whatever it is, everyone's different. So I think fundamentally it comes back down to going to a place that sees a lot of stuff, sees a lot of this stuff, and then having a great relationship with your team there, and knowing that they have a multidisciplinary team that are likes of me and Holly that will argue with each other on the patient's behalf, where you're best advocate, and kind of going from there.
What I am loving is a couple of things with this discussion. And first of all, one of the things that I'm hearing that I think you all do particularly well with the care pathway, and also just almost by the nature of the global care in the UK, is the duration of preoperative physiotherapy or conservative management. And I know I hear a lot. So I am also a physio, and I know a lot of patients, though, I hear where it's the surgeons are going, well, you have to do 6 weeks of physical therapy. And I mean, I think we can all agree that, there's lots of roles for physical therapy. And some patients are just like, why am I doing this physical therapy? Because I have a surgical issue. Why would I do physical therapy? It's not going to help me. And if they go into it with the mindset that it's not going to help, that already is probably going to set it up for a certain response or lack thereof. So I think the language and the communication around this is so important. I also love that even if you're listing a patient for surgery, that there is still a role for the physical therapy management, because to some of these points, I think my personal experience, and Holly, and just anecdotally from patients I know, that the better shape you can get yourself into before surgery, and the lower you can, the more you can lower that pain, even if it's still a surgical outcome, I think that can really set someone up for success, or at least make it an easier surgery and recovery process. But like you said, there's also still that opportunity then too, that I don't think we speak enough about, that of, is there a role for purely conservative management? I mean, Holly, you're an incredible example of someone who's shown that conservative management is possible, perhaps in some patients. And like you spoke to, there's probably a need for us to better fine tune patients. And is it truly individual characteristics, or there may be group characteristics that are going to pan out over time, of saying, that would help us better predict and communicate, and set up expectations for patients and prognosis. So fascinating. And I think you both kind of jumped onto my next question, and probably I already know some of the answers, but would love to hear what priorities or opportunities you see for hip dysplasia related care, research, or education in the UK, and then any activities or that you're actually involved in or aware of going on to address those.
Holly, do you want to cover that one, or should I start?
Absolutely, you start.
Okay, well, research priorities, or priorities in general for what we can improve. Let's think of it that way. What do we need to get better at? I think we've outlined already that we need to be getting better at educating our primary and secondary medical professional partners to recognize this early, so we diagnose hip dysplasia in adults quicker, and they all have a regional, at least, place to refer to. I think that's an important one. The second thing we all collectively need to get better at is multidisciplinary team meetings. I think what you're seeing here is a good interaction between people who trust each other, and have the value. I value a physiotherapist's opinion, and a radiologist opinion, and a chronic pain team colleague of mine, and so on and so on. And I think having the strength in unity there is very important. And what I mean in terms of improvement is making that near mandatory. Every patient should undergo that thought process before making life-changing decisions, or at least suggesting life-changing decisions for them. On a research side of things, one of the things I will say that the UK has been pretty good at doing is having the United Kingdom non-arthroplasty hip registry, so it's the NAHR, and it's over a decade old, and there is an obligation rather than a legal compunction for all hip preservation surgeons to contribute data on every single patient, anonymized, of course, and so on, to this amazing registry. And then the guys in Cambridge and London and Northumbria, they've been doing an awful lot of fantastic research, mining through thousands and thousands of patients. But still, we know that our take-up rate of procedures patients having procedures and then being on that registry is pretty low. I don't know what the numbers are, but I think 50% would be even higher than what we're achieving. So I think we need to drive more patients into these registries, anonymized registries, to understand more about what we're doing, because weirdly enough, what we're talking about is relatively nascent. Gantz and colleagues in Bern started talking about this stuff in my lifetime. So really, there's so much to learn. And then the last thing I will say is that we need to get better at understanding what conservative measures are best, at what point they need to be deployed, who they're best for, and what recovery looks like as well, and how to optimize our outcomes. Because it's not straightforward, but it's a technical procedure, what a surgeon does, but actually what happens before and after is a patient journey, and that really we don't have a good grip on. And then I won't hammer this point too far home, but my personal interest in research is that we don't really know which patients are going to do really well. We don't really know how to get the correction perfect yet. And my personal research at Imperial and UCL is related to 3D planning, and also AI uses of MRI in a field called radiomics, where we're looking at the texture of each single pixel and voxel in MRI scans to work out which patients may have passed the threshold of preservation, for example, which patients are going to be symptomatic on one side, but asymptomatic on the other side. So there's lots of things we need to understand. I think AI is going to be a huge thing for the next, well, already now, but coming 5 years or so, telling us more about how hip dysplasia works and which patients benefit from what kind of therapy. Holly, over to you.
So then for me, I think I'm working quite hard on trying to raise the profile of hip dysplasia in universities, because as we mentioned earlier, it may be one slide on hip dysplasia in an undergraduate degree. And then again, in masters, it might be a slide, it might be a few slides, but it hasn't had the exposure that impingement generally has. So I lecture on various university courses, masters, specifically for a whole hour, which is a master's at UCL. But then, just trying to raise it in the undergraduate courses as well. Trying to raise the awareness with the primary care GPs and radiologists, so that it's not just, is it arthritic? Is there a fracture? We're asking the question in a young female, is there a stress fracture is a key one, but also, AVN or dysplasia. We need to be kind of thinking of a spectrum of diseases and pathologies. That is the main question that we would look at that come back, not just arthritis or fracture, so that we're not missing those dysplasias. And then we also, Kartik and I all spoke about optimizing length of stay and kind of reducing that. And that's the whole MDT pathway. So, when I had my PAO in 2011, I had an epidural, I was in for a long time. I was a terrible patient, did a lot of passing out, the full works. I was sick on the physio student. It's a course. We all have to learn, don't we? But now, some places are moving towards, well, Nancy, didn't you have a very short stay?
Yes, so I've had 4 PAOs now, and my first one was 2 nights, and my other 3 have all been an overnight. So definitely very, very short, but
So
even that has.
I mean that is exactly where you all need to be. I mean, I'd say our current experience is a couple of nights, in hospital in UCL, and then we have colleagues in Ottawa who recently published a fantastic paper on day case PAO. So this comes down to, again, a really good relationship with the patient in terms of what the targets are, what is expected of the surgeon, the team, even of the patient in terms of when you plan to go home, but also, as Holly was saying, optimizing the perioperative anesthesia, getting pain control exactly right, and fluid management right, and so on and so on. So everything we've talked about this evening is about the team. So for so long, surgeons, anaesthetists, physios have worked in silos, but particularly with something in patients who are often young, high demand, otherwise physically relatively well, the combination of a good surgical team, anesthetic team, and a rehab team, it's exactly what we need to kind of take the specialty forwards.
Oh, I love it. And sorry, Holly, you look like you have another comment.
Oh no, so I was just going to say then, obviously for me, it's kind of optimizing that conservative pathway, because we don't have any consensus. We had the wonderful North American group did a post-op and a conservative consensus, but just with the North American group. So we need worldwide consensus. We need to bring everyone together. We need to see what we're all doing around the world, what we think works, what we think doesn't work. We then need to optimize those care pathways, so we're operating on the right patient at the right time. They've had the right rehab. We know that it's failed, and that therefore they are requiring that surgery, because it's a major undertaking for a patient to go through. And we just don't have any understanding. We have lots of us that are classed as experts around the world. And, even with my colleagues, I went recently to Denmark and did a whole traveling fellowship. And some of the things that I do differs very much to what they do. But, the patient's feedback that it really helps. And so, who's right? It's all patient preference, but outcomes. And we need to have that evidence, and we need to have that research. So that's my drive, is building that clinician awareness. I'm working on lots of projects with various people around the world to build that clinician awareness, and then build those pathways, which is kind of my main role at Cambridge. Is what I'm doing is trying to optimize that, trying to prove that they work, trying to prove that we can see those groups that, again, I know and I discuss with my expert colleagues that they exist. I can get this patient better, I can't get that one. There's all these factors to it. It's so multifactorial. And so who's going to fail? Who's going to do good? Picking winners, both from my side in the conservative management, because I want to pick my winners. And Kartik, as a surgeon, wants to pick his winners. And then how do we unpick the ones that haven't had the optimal outcomes that they should have done? And why is it? And was it that the rehab was wrong? Or was it that the surgery wasn't quite right and they're overcorrected and now they're impinging? There's so much we don't know in dysplasia. So I just want to see that, it's picking up momentum now on the research side, and that we're getting more and more and more out there, because there's just been nothing.
And I can say on my end, as coming at it from a patient standpoint, also in working in healthcare, but also from a research standpoint, I think I'm very excited about you all maintaining this registry. I know in the United States, there are a couple, the Anchor Group has done some work maintaining a registry, but there's not a national registry. And I will even say, with many of the surgeries I've had, my surgeons have no idea how I've done. If I'm having a problem and I go back to the surgeon and they can't offer anything further, I'm going to go get another opinion, and there's no record that that ever happened. And so I think tracking the outcomes, first of all, tracking the variables that we think might play into outcomes is so important preoperatively. I mean, Holly, you've even mentioned that you all are screening anxiety, depression, looking at mental health, looking at chronic pain. I mean, there's just so many variables in here. Like you said, we want to pick the best candidates for both pathways. There's not a right or wrong pathway. There's roles for both pathways. But picking the best candidates is how you're going to get the best outcomes overall, and then tracking long term. So down the road who's doing well at 2 years, but also who's doing well at 5 or 10 or 20 or 30 or longer, because that's how we also learn and grow through it. So anyway, I'm very excited about both of your passions and the questions you're bringing up, and in the work that you see. And kind of on that note, I'd love to just finish on a positive note, but what is your vision for the future of hip dysplasia? What would you both like to see?
I think we've discussed about what the weaknesses are really and the strengths of what we're doing right now. Mm-hmm. I think, just to summarize, really, the vision is to have centers of excellence with people who are seeing lots and lots of this problem, who are familiar with how patients feel, assess them in a very holistic, multidisciplinary fashion, from chronic pain right through to their numbers, and then deliver evidence-based, world-class conservative and surgical therapy, and have excellent records and registries of how those patients do, and track them and understand more, feed it back to the next generation of patients who need this, and also continue to distribute the little we learn every few months or years to our community practices, and to our physiotherapists and medical students and so on. So the vision is just improving care in every sense. And finally, I mentioned already, the big leap forwards is that we have this incredible repository in many places, Anchor or the NAHR or what have you, of patient details and demographics and patient-reported outcome measures and MRI data and CT data. And I think the era now of understanding what big data is and how it comes together is probably here. So I think the vision as well is to finally start putting bits together, so linking things we didn't see before, to understand a bit more about hip dysplasia and working out which patients we can help and which patients require something else, and so on.
Wonderful. And Holly, I'll let you share as well.
I think that was an incredible summary. I think if I put on a little bit of a patient hat, as well as that incredible summary from Kartik, is as a patient, just promoting that education and that awareness and that understanding, because I think being hit with that huge word and then being told a huge word of a periacetabular osteotomy. And that journey you then go on as a patient, I think everything that Kartik just alluded to is going to change that pathway for each individual patient. And we just have to do better. That pathway has to be more streamlined. It has to be much clearer. It has to have the gold standards of everything. We have to be able to offer patients the most exceptional evidence-based care. And that pathway should be slick. And I think, sadly, a lot of the mental health side of this comes out of not being believed for many years, the delay in diagnosis. And I would hope that we now are doing better around the world, and that continues to improve for our patients, because that will only improve their pathway to then understand, right, if I want to PAO, the option's there. Okay, the option's not there. How long do I have to wait? And when's the right time to do a hip replacement? Because I'm in loads of pain, but I haven't got frank arthritis. So that's another argument and a discussion that we also need to improve. So there's so many things that we need to improve, and that will only move forward with the exceptional work that is being done around the world, and that collaboration and the MDT coming together. So that's my vision, is just that's why I wrote and put forward the piece of research that I did along with MJ Sharp, where we looked at what patients wanted, what clinicians wanted, and that actually there wasn't much out there. And so we wrote that hip dysplasia leaflet, because patients are just hit with so much information of stuff they don't understand. And that's what's got to change, in that we have that clarity.
Well, wonderful. Well, I am so appreciative of both of you spending your evening speaking with us, and I know our entire community is really going to benefit from listening to this interview. I've had a wonderful time getting to speak to both of you.